Imagine a newborn, just a few days old, who suddenly has a seizure. Now imagine a different newborn, same age, same kind of seizure on the surface. But one of these babies will likely outgrow it within weeks with no lasting harm. And the other faces a lifelong severe neurological condition. How do doctors tell these two apart? And why does getting that answer right fast change everything? That's what this video is about. We're walking through the International League Against Epilepsy's 2022 position statement, the official framework that classifies and defines every major epilepsy syndrome that begins in the first 2 years of life. By the end, you will understand not just what these syndromes are, but the logic doctors use to sort them. Let's get into it. First, why focus on neonates and infants specifically? Because this is the highest risk window for epilepsy in the entire human lifespan. The incidence of epilepsy is age dependent and it peaks at the extremes of life, in children under 5 and in adults over 65. But the very first year of life is in a category of its own. Population studies show an incidence of roughly 82 to 118 per 1 lakh person years in the first year, compared to about 46 per 1 lakh in older children. One recent prospective study found 75 per 1 lakh live births before 6 months of age. And it's not just common, it's consequential. Epilepsy starting this early carries a high burden of cognitive and behavioral problems, higher rates of drug resistance, and higher mortality. Up to 50% of these children show global developmental delay just 2 years after they first present. So the stakes are enormous, and that's exactly why classification matters, because the name you give the condition carries information about prognosis, treatment, and what to watch for. So what is an epilepsy syndrome? The ILAE defines it as a characteristic cluster of clinical and EEG features, often supported by specific etiological findings, meaning structural, genetic, metabolic, immune, or infectious causes. 3 things to hold on to. A syndrome diagnosis carries prognostic and treatment implications. Syndromes are often age dependent in how they present. They come with their own specific set of comorbidities. The big conceptual shift in this 2022 document is that the task force builds etiology, the underlying cause, into the definition itself. Classification is now a hybrid, electroclinical features plus cause. One cause can produce several syndromes and one syndrome can have many causes. But in some cases, a specific etiology produces such a consistent recognizable picture that it becomes a syndrome in its own right. Here's the master map. The task force divides all these syndromes into 2 major groups. Group 1 is the self-limited epilepsy syndromes. Self-limited means there is likely to be spontaneous remission. The seizures typically respond to medications, and cognition is usually normal or only mildly affected. Note the language. The old world benign has been retired in favor of self-limited because benign undersold the experience for families. Group 2 is the developmental and epileptic encephalopathies or DEEs. This is the severe end. The key idea is that developmental impairment comes from 2 sources, the underlying cause itself and the damage done by the relentless epileptic activity. Both contribute. And then layered on top, there's an emerging third concept, etiology-specific syndromes, where a specific genetic or structural cause defines the syndrome. Most etiology-specific syndromes that start this early are DEEs. Now the engine that makes this whole system usable at the bedside. For every syndrome, the task force defines 3 tiers of criteria. This is the part clinicians actually use. So let's be precise. Mandatory criteria must be present. If a mandatory criterion is missing, you cannot diagnose the syndrome. Alerts are features that are usually absent but can rarely appear. An alert alone doesn't rule out the syndrome, but it should make you stop, rethink, and investigate further. The more alerts stack up, the less confident you should be. Exclusionary criteria must be absent. If even one is present, the syndrome is ruled out. This mandatory alerts exclusionary structure repeats for every single syndrome we're about to cover. Keep it in your head. It's the grammar of the whole document. One more crucial point before we dive in. The task force deliberately built this for all clinicians, not just those in well-resourced hospitals. For each syndrome, they specify whether it can be diagnosed without EEG, MRI, or genetic testing, because in many parts of the world, those tools aren't available. Carefully defining the syndrome clinically can often suggest the etiology and guide treatment even without a lab. That's a thread you will see run through every syndrome. Let's start with the good news group, the self-limited syndromes. These are the babies who in most cases will be just fine. First, self-limited neonatal epilepsy or SELNE, formerly called benign familial neonatal seizure. When seizures classically start between days 2 and 7 of life. What they look like? Focal tonic features affecting the head, face, and limbs, and they may alternate sides from one seizure to the next. And autonomic features like apnea and cyanosis show up in about a third of seizures. Incidence is about 5.3 per 1 lakh live births. The course: seizures usually remit by 6 months, most by 6 weeks. Development is usually normal, though up to a third may have seizures later in life. Genetics: this is the headline. It is autosomal dominant, and KCNQ2 is the most common cause, present in about 80% of cases. KCNQ2 and KCNQ3 code for potassium channel subunits that form the M channel. The critical distinction SELNE is benign, but a different mutation in the very same gene KCNQ2 can cause a devastating DEE. Same gene, opposite outcomes. We'll come back to that. The thing that excludes this diagnosis: any degree of encephalopathy. A baby who is encephalopathic does not have self-limited neonatal epilepsy. Next, a closely related cousin: self-limited familial neonatal infantile epilepsy, SELFNIE. This one is defined by its spread of onset ages across a family. Some family members have onset as neonates, others as infants. That mixed pattern is the signature. Onset ranges from 1 day to 23 months, mean around 11 weeks. Seizures are focal tonic features with head and eye deviation, non-tonic and clonic features. Some have prominent apnea and staring. Genetics: primarily SCN2A, the sodium channel gene. Autosomal dominant, high penetrance. Course is: seizures cease by 12 to 24 months, no later recurrences, readily controlled with medications. Then self-limited infantile epilepsy, SELIE, formerly benign familial infantile seizures. When onset 3 to 20 months, peak at 6 months. How common? This one's relatively common. It accounts for 7 to 9% of all epilepsies beginning before age 2. Incidence about 14.2 per 1 lakh. Seizures: focal seizures with behavioral arrest, staring, impaired awareness, automatisms, head and eye version, clonic movements, brief, under 3 minutes, but can be frequent, like 5 to 10 a day for a few days. The genetics twist: PRRT2 is the most common gene. And here's the fascinating part: PRRT2 also links to a movement disorder. Some patients develop paroxysmal kinesiogenic dyskinesia later in childhood or adult life. There's even a familial syndrome, infantile convulsions with choreoathetosis, where family members have seizures, the movement disorder, or both. What rules it out? Epileptic spasms or myoclonic seizures. Those point elsewhere. Now, a spectrum rather than a single syndrome. Genetic epilepsy with febrile seizures plus, GEFS plus. Think of GEFS plus as a family umbrella. Within one family, you can see classic febrile seizures plus, which means febrile seizures continuing past age 6, the usual stopping point, and a range of other epilepsies, all the way up to Dravet syndrome at the severe end. So mandatory is febrile seizures, which may be generalized or focal. Genetics is heterogeneous. SCN1B was the first gene found, but SCN1A is the more important one, found in about 10% of GEFS plus families. Many other ion channels and receptor genes are involved too. Inheritance is autosomal dominant with variable penetrance. A warning sign embedded here: prolonged focal clonic, hemiclonic seizures with fever before 15 months, especially if recurrent, should make you think Dravet, not simple GEFS plus. Last in the self-limited group, myoclonic epilepsy in infancy, MEI. The seizure, myoclonic seizures involving the head and upper arms, are mandatory. In about a third of cases, they are reflex triggered by sudden noise, touch or startle. When onset between 4 months and 3 years, peak 6 to 18 months, boys roughly 2 to 1. Half rare, vary, under 0.8% of children with epilepsy at a specialty center. Course, myoclonic seizures remit in nearly all cases, and most children come off medication. Long-term development is normal in 63 to 85% of cases. The critical task with MEI is to confirm the myoclonus is epileptic and to exclude infantile spasms, which are far more common and far serious. That's why an EEG with video and EMG is mandatory. Epileptic spasms, tonic, absence and focal seizures are all exclusionary. Now we cross over to the severe end of the spectrum, the developmental and epileptic encephalopathies. Remember the core idea: the developmental harm here comes from both the underlying cause and the epilepsy itself. The foundational one is early infantile developmental and epileptic encephalopathy, EIDEE. This is the landmark change in 2022 classification. EIDEE merges two older famous syndromes, Ohtahara syndrome and early myoclonic encephalopathy, into a simple entity. Why? Because their electroclinical features overlap heavily. They share underlying causes, and many infants didn't fit neatly into either box. Separating them, the task force concluded no longer helped clinical decisions. When onset in the first 3 months of life exclusively, seizures, tonic and myoclonic are mandatory. Can also include epileptic spasms, focal clonic and sequential seizures, where multiple seizure types flow one into the next without a single dominant type. EEG, the hallmark is burst suppression, high voltage bursts alternating with near flat suppression, or multifocal discharges or diffuse slowing. Incidence is about 10 per 1 lakh live births. The bottom line: seizures are usually drug resistant, and almost all infants end up with moderate to profound intellectual disability. But here's the hopeful thread: neuroimaging, metabolic and genetic testing can pinpoint the cause in about 80% of the cases. And cause matters because some are treatable. SCN2A and SCN8A respond to sodium channel agents. Pyridoxine-dependent epilepsy responds to vitamin B6. Finding the cause can change the outcome. The genotype often predicts the phenotype. KCNQ2, SCN2A, STXXBP1, CDKL5, KCNT1 each tends towards a characteristic seizure pattern. Next, epilepsy of infancy with migrating focal seizures, EIMFS, formerly called malignant migrating partial seizures. The defining feature is right in the name: migration. Focal seizures arise in both hemispheres and physically migrate from one cortical region to another. within a single seizure. On EEG, you can watch the discharge travel. When? Usually the first 6 months, mean 3 months. Seizures, focal motor clonic or tonic, initially sporadic, then rapidly escalating, often into status epilepticus. Genetics, mainly genetic with KCNT1, the major gene, found in nearly half of the cases. Over 25 other genes are linked. Prognosis, poor, severe disability, microcephaly developing by age 1, reduced life expectancy. A nice point on equity. Because the migration can sometimes be seen clinically, EIMFS can be provisionally diagnosed on observation alone where EEG and MRI aren't available. Myoclonic seizures are exclusionary. This is one of the most important syndromes in the entire document, infantile epileptic spasm syndrome, IESS. IESS is a deliberately broad umbrella. It includes the classic West syndrome, the triad of epileptic spasms, hypsarrhythmia, and developmental stagnation. But also the many infants who have spasms but lack one of those 3 features. The task force widened the definition on purpose, because waiting for the full triad delays treatment, and time to treatment is one of the strongest predictors of outcome. Mandatory is epileptic spasms, brief tonic contractions of axial muscles under 3 seconds, flexor, extensor or mixed, usually in clusters, often on awakening. When? Onset 1 to 24 months, peak 3 to 12 months. EEG, hypsarrhythmia, chaotic, high amplitude, multifocal is classic. Best caught in non-REM sleep, but it can be absent and the document is emphatic. Do not withhold treatment just because hypsarrhythmia isn't there. Incidence about 30 per 1 lakh live-born infants. Causes, MRI is abnormal in 1/2 to 2/3 of cases. Genetic causes are found in up to 41%. Trisomy 21, ARX, CDKL5, STXBP1, TSC1, TSC2 and many more. Course is about 30% evolve into Lennox-Gastaut syndrome. Outcome hinges on cause and on prompt treatment. The word epileptic was deliberately added to the name to stress that these were true seizures and avoid confusion with non-epileptic spasms. And the most famous name in infantile epilepsy, Dravet syndrome, DS, formerly severe myoclonic epilepsy of infancy. The task force deliberately kept the eponym Dravet, one of the few exceptions to the dropping eponymous names, because the term is so deeply embedded in research, clinical trials and orphan drug registration. The classic story, a normal infant in the first year of life has prolonged seizures, fever, febrile and afebrile that are focal clonic, usually hemiclonic or generalized clonic. A prolonged hemiclonic seizure with even a low-grade fever before 12 months in a previously normal baby with no infection or structural cause, that is highly suggestive of Dravet. The evolution. Between ages 1 and 4, other seizures types appear. Myoclonic, atypical absence, focal, impaired awareness. From the second year, cognitive and behavioral impairment sets in. A characteristic crouch gait appears by late childhood. Genetics, SCN1A, is found in over 80 to 85% of cases, mostly de novo. But up to 10% of de novo cases actually have a parent who is mosaic, which matters enormously for reproductive counseling. The treatment trap. This is critical. Sodium channel blocking drugs like carbamazepine, lamotrigine, oxcarbamazepine and phenytoin worsen Dravet seizures. Good efficacy with those drugs is actually an exclusionary clue against Dravet. And the document stresses, Dravet is a clinical diagnosis. You cannot diagnose it on the gene alone, and the absence of the gene does not rule it out. Now the frontier, the newest concept in the document, These are syndromes defined primarily by the cause, where one specific etiology produces such a consistent picture that it earns its own name. The task force defined a limited set. They stress the number will keep growing. Remember KCNQ2 from the benign neonatal syndrome? Here's its dark twin, KCNQ2-DEE. Same gene, completely different disease. This is caused by de novo missense variants that produce a dominant negative, much more severe loss of channel function. Seizure onset is in the first few days of life, but in the context of a severe neonatal encephalopathy, that's what separates it from its benign SCLNE. EEG, over 60% show burst suppression. Treatment: seizures may respond to sodium channel blockers, carbamazepine, phenytoin. So these should be considered early. Outcome: epilepsy often remits and over half become seizure free, but development is typically moderately to severely impaired. This is the purest illustration of the document's central theme. The gene alone isn't the diagnosis. The type of the variant and the clinical picture decide whether you're looking at the baby who recovers or a baby with a lifelong encephalopathy. Now, the most treatable syndromes in the entire paper, and that's why they matter, out of all proportion to their rarity: pyridoxine-dependent DEE, ALDH7A1, and pyridoxamine 5-phosphate-dependent DEE, PNPO. These are genetic metabolic defects in the same lysine degradation pathway. And here's the remarkable thing: seizure control can be achieved in almost all cases with pharmacological doses of vitamin B6, pyridoxine or pyridoxal 5-phosphate, respectively. The presentation, often shortly after birth with encephalopathy and drug-resistant seizures, sometimes even intrauterine convulsions. The picture of a hyperkinetic agitated infant with multifocal myoclonus and spasms should raise the flag. It can mimic hypoxic ischemic encephalopathy. The imperative: because they are treatable, the document says these must be considered in every infant with drug-resistant seizures. The biomarkers are alpha AASA and pipicolic acid. The catch: even with good seizure control, most still have some degree of intellectual disability. But earlier treatment means better outcomes. So, speed matters. Treatment is lifelong. Withdrawing B6 brings the seizure back. CDKL5-DEE is also called CDKL5 deficiency disorder. When? Very early, median onset 6 weeks, 90% before 3 months. The signature: the combination of infantile spasms and tonic seizures in the first months, plus pronounced hypotonia. One characteristic seizure is the hypermotor tonic spasm sequence. A hyperkinetic phase, then tonic, then a run of spasms. Genetics: X-linked, but females outnumber males 4-1. Incidence between 1 and 40,000 and 1 in 60,000. 3 stages. Stage 1, early onset with brief tonic seizures. Stage 2, encephalopathy with tonic seizures and spasms. Stage 3 is late multifocal and myoclonic epilepsy. Outcome: drug resistant, severe to profound intellectual disability in essentially all cases. Cortical visual impairment is common. PCDH19 clustering epilepsy, a genetic puzzle with a unique inheritance pattern. The signature: clusters of seizures often triggered by fever, frequently with fearful screaming, head and eye deviation, pallor and expression of fear. When? Onset usually before 1 year, mean 10 months. The genetic oddity: it's X-linked but works backwards from intuition. It affects females and spares transmitting males because of presumed cellular interference. Only heterozygous females and mosaic males are affected. Roughly half of cases are de novo. Incidence about 1 in 42,000. Comorbidities, intellectual disability and autism spectrum disorders in about 70%. How to tell it from Dravet? Dravet has prolonged hemiclonic seizures. PCDH19 has clusters. Both are fever triggered. Both hit in infancy. But the pattern and the female predominant X-linked inheritance set PCDH19 apart. Glucose transporter 1 deficiency syndrome, GLUT1DS, and this one has a beautiful, almost elegant logic. The defect is in SLC2A1, the gene for the glucose transporter that ferries glucose across the blood-brain barrier. So, the brain is in effect starving for fuel. The triad of clues: infantile onset epilepsy, a movement disorder, and intellectual disability. Look for seizures linked to fasting or early morning, plus eye-head gaze saccades, plus microcephaly in about half. The diagnostic test: a lumbar puncture shows low CSF glucose. Hypoglycorrhea with low CSF to plasma glucose ratio after a fast with normal blood glucose. Incidence presenting as infant epilepsy in about 1 in 24,000. The treatment: this is the payoff, the ketogenic diet. If you can't deliver glucose to the brain, you give it in an alternative fuel, ketones. With adequate ketosis, seizures can be completely controlled. Lack of improvement on the ketogenic diet is actually an exclusionary clue against the diagnosis. Sturge-Weber syndrome, SWS, the only one you can sometimes spot at birth with your eyes. It is a congenital neurocutaneous syndrome, a facial port wine stain birthmark paired with a leptomeningeal angioma, abnormal blood vessels over the brain on the same side, and frequently glaucoma on that side too. Cause: a somatic activating mutation in GNAQ. Interestingly, the same mutation causes isolated port white stains. SWS is what happens when it also affects the brain. The risk: a child with a port wine stain on the forehead or upper eyelid has a 20 to 70% risk of SWS. Seizures: usually the first manifestation in 75 to 85% of patients. Median onset 6 months. First seizures are typically focal motor. EEG: asymmetric reduced voltage and slowing over the affected hemisphere. Diagnosis: confirmed by contrast enhanced MRI showing the leptomeningeal enhancement. Early seizure onset, high frequency and drug resistance predicts the worst outcomes. So, early recognition and a rescue medication plan for parents are emphasized. And the most unusual presentation of all, gelastic seizures with hypothalamic hamartoma. A hypothalamic hamartoma is a rare congenital non-cancerous lesion. Its signature seizure is gelastic, from the Greek for laughter. The child has episodes of mechanical, mirthless laughter, completely inappropriate to context, usually under a minute, often many times a day. Sometimes they are dacrysistic seizures too, stereotyped crying. The combination of both is especially suggestive. When? Onset in the first year of life in about 85% of cases. A telling detail: awareness is often not impaired and there is no postictal confusion. And smiling alone without that mirthless quality does not count as a gelastic seizure. Other features: precocious puberty in some, over time cognitive plateauing and behavioral problems, aggression, impulsivity. Diagnosis and treatment: MRI is mandatory, and here's the key surgical insight. On scalp EEG, the seizures may look like they come from the temporal or frontal lobe, but depth electrodes prove the hematoma itself is the source. So surgery must target the hematoma. And early surgery can both control seizures and prevent the cognitive decline. Step back and you can see the philosophy of this whole document in a few deliberate choices. They retired stigmatizing words. Benign became self-limited, malignant and severe were dropped. partial became focal, convulsions became epilepsies. Language shapes how families experience a diagnosis. They merged what overlapped. Otahara and early myoclonic encephalopathy became one, EIDEE. They broadened what was too narrow. West syndrome strict triad became the more inclusive IESS, so treatment isn't delayed. They kept what was useful. Dravet stayed for practical research and drug development reasons. And they introduced etiology-specific syndromes, the bridge to precision medicine. If you remember nothing else, remember these two threads woven through every syndrome. 1. Same gene, different disease. KCNQ2 can be benign or catastrophic. SCN1A spans GEFS plus 2 Dravet. The gene is the clue, never the whole answer. The clinical picture decides. 2. Etiology is destiny and sometimes it's treatable. Paradox-independent epilepsy responds to vitamin B6. GLUT1DS responds to ketogenic diet. Finding the cause fast isn't an academic exercise. It can change a child's entire life. That is the hope precision medicine brings to these devastating conditions. So, back to our two newborns from the start. The difference between them isn't visible in that first seizure. It's in the pattern, the cluster of EG findings, the development, the family history, the cause. That's what this classification gives doctors. A shared language to read those patterns, sort out the self-limited from the severe and act in time. If this helped the framework click for you, the full ILAE position statement is open access in Epilepsia 2022, citation on screen. I'd really encourage clinicians to read the original tables in full. Thanks for watching.